Thank you very much for having me here today. It's always a pleasure to share findings and ideas between centers. So I'm getting this right. Great. So I will kind of give you an overview of the work that we're doing in the center. So it's going to be the breadth of what we're doing and maybe not the depth, but I'd be happy to have questions after. The name of our center is CIRCLE, for a Center for Integrative Research on Child and the Environment. So first off, I just want to give you some fact about childhood leukemia. About 1 out of almost 300 children will be diagnosed with cancer. The most common cancer in children is leukemia. It represents, about a third of all cancers. What we know from leukemia is that over the past decades, the treatment has improved quite a lot, thankfully, to increase remission, and many of those children in general will survive. However, this has a cost, as you can imagine, as a child and a parent, to have to go through very toxic chemotherapy, radiotherapy. Any additional, adjuvant treatment has quite profound impact later in life in terms of other collateral medical condition, psychological complication, but also financial actually complication and impact on the family as well. So bottom line, treatment has improved, but the key is prevention. And I think it goes nicely to what Bruce was saying before. Yes, we do well on treatment, but what about preventing? So what's happening with childhood leukemia in the United States? We can see here data that are going back to the late 80s are actually showing an increase in incidence over time. So maybe those little points don't seem to add up, but they actually do add up. After 30 years of time, you have many more cases of children who will develop leukemia. When we look at data, and many different groups have looked at this descriptive data, and we are actually also in the process of doing this with Mark Miller and colleagues from the California Cancer Registries, but those are existing data that are showing that in blue you see the overall, in green you see the overall incidence rates, the trend. But in blue on the top you see that the one that have the highest rates of childhood leukemia with the actually an increasing trend are Hispanic children, Latino children. The higher incidence of childhood leukemia in California is seen in among Hispanic children, as well as in all the United States. However, a large majority of Latino children. So what is happening here with this, increase, very high rate of childhood leukemia among Hispanic children? You can imagine that only genetic influence could not explain such an increasing trend in a short period of time. So environmental exposure have to have some impact on this pattern. What's interesting to see as well is that African American has been so far protected. I mean, they have a low rate of childhood leukemia. However, their increase in rate is actually the largest right now. It's 1.7. So things are changing. The lines are moving. Other interesting statistics that do help us to pinpoint our research and to focus on specific windows of exposure is that the age distribution of the disease is very specific. You will see the term ALL and AML. Childhood leukemia is mostly include what we call acute lymphoblastic leukemia, which represent about 80% of all leukemia. So we call those ALL. There's a rare subtype which is called acute myeloid leukemia. So if I focus on ALL, you can see that the peak incidence is between the age of 2 to 4. This is when we will have the most children diagnosed with ALL. We see this trend for both Hispanic and white and African American. But you can see the AML trend doesn't seem to, is kind of across all ages. So that's an interesting observation by itself, which has led to look carefully at preconception period and in utero exposure, as well as postnatal. And one of the main hypotheses that are kind of matching the natural history of leukemia is that we believe that there is a need for more than one event to lead to a leukemic cell, and that some of the initiating events could actually happen before birth, either preconception or during pregnancy. And any additional damage in the postnatal period could help to push this damaged cell into a cancer cell. So we've been looking carefully at the pre and postnatal exposures. Add some complexity. Childhood leukemia, I mentioned ALL versus AML, but when you look at the molecular characteristic of the disease, they are very different depending on age. When we focus among children, 1 to 15 years old, you can see that the main molecular subtypes are what we call hyperdiploidy. That means there's an extra chromosome. The second most common subtype is called what we call translocation 1221. It's a very, very specific subtype of childhood ALL, and my colleague Scott will be talking about this later. So you see the distribution of molecular subtype has this pattern here among children from 1 to 15. Believe it or not, infant could be actually born with leukemia, and this is a very, very specific situation where a very young child, less than 1 year old, can develop leukemia. And those children usually have a different molecular pattern. They have what we call gene fusion, 11q23 gene fusion. So you see, that gives you an idea of possibly different pathway that could lead to different subtype of leukemia. And of course, this is in contrast to what we know about adult leukemia. It's a completely different pattern. So we have some clues about the age distribution, and we have also some ideas about maybe a specific cause that will lead to specific subtypes. So with this in mind, our center was formed about 6 years ago to try to bring together different aspects of research that we've talked before. It's going to be almost a deja vu, but looking at childhood leukemia. We focus on chemical exposure, genetic and epigenetics. And most of this work comes primarily from a study that started in California, the California Childhood Leukemia Study. What I would like to bring to your attention is that leukemia is still a very rare event in children compared to cancer in adults. So that brings a lot of challenges when you want to study a rare disease that is heterogeneous. In order to do that, we were also very interested in working in collaboration with studies around the world to help bring forces and add numbers. Our study during the period of 1995 to 2015 enrolled about 1,500 cases of childhood leukemia. This is a lot of work for 20 years compared to the numbers of breast cancer you can accrue. It's a lot of work, but that study was very was in depth in terms of characterizing the disease and characterizing the exposure. When we worked with the Childhood Leukemia International Consortium, which combines data from about 23 plus studies, mostly in Europe, mostly in Northern America. We do have colleagues from Costa Rica, from Brazil, from Egypt, we do have colleagues also in Australia and New Zealand, but most of the studies, I would say, because of the resources, have been done in Europe and Northern America. But look, we were able to accrue 1,500 cases over 20 years. When we work with all those studies, we could go up to 38,000 leukemia cases and hundreds of thousands of controls. However, there's a balance here. Large numbers mean not always detailed, good data. You have a trade-off. So out of these numbers that seems impressive, I would say that up to now, we have really worked with studies that have extensive epidemiologic data and that represent about 15,000 cases and 2,400 controls. But still, it's more than anybody can do. So we have seen this list of usual suspects for a different outcome in children. We've talked a lot about immune regulation in the context of prior disease. This is definitely a line of research that is very relevant to childhood leukemia, knowing that this is a cancer of the lymphoid cell most of the time that are responsible for your immune function and immune response. So this is a very important line of research. I will not go in details today. We have looked at also birth characteristics in terms of the fetal growth, but a lot of my work has been done around environmental exposure at home, but also where the parents are working, because remember, things could happen before the child was born. Parents are exposed before conception, and that could have an impact. We have looked at outdoor pollution, other form of radiations. I will not go in details, and we have looked at diet. Those environmental exposures are not coming out of the blue. Most of the time, they are known carcinogen for adult cancers. So we know those are bad players to even start with. Not only they can be genotoxic, but we have heard today that they can also have impact on the immune system. We've heard about pesticides, we've heard about PCBs, PBDEs. So things are complex. We kind of cross a lot of different pathways here. So let me go over some of the findings that we have, again with the idea that we started with the California Childhood Leukemia Study, but we worked with the Childhood Leukemia International Consortium to help us when we have rare subtypes, to help us to validate our findings, to help us to look at modifiers. So I will always go back and forth, and you will see the little logo when it's the California study, and you will see the click logo when it's the International Consortium. So in our study, we looked at the risk of childhood ALL in relation to smoking. We looked at maternal smoking before conception, before birth, which include preconception and pregnancy, paternal smoking, and child's passive smoking at home. Consistently, studies have found no association between a mother who smokes during pregnancy and leukemia, which sounds to be completely out of the order. I mean, smoking being such potent carcinogen, it's hard to believe. However, there may be different reasons for that. Recall bias could be a big one. Who would admit that you were smoking during pregnancy? There could be some competitive risk. Smoking is known to be genotoxic anyway, and a child may not actually, fetus may not survive a pregnancy being exposed. So there may be different reasons for no association. We'll go into details later. And then we have those kind of small magnitude association with being the father, smoking fathers and child being exposed after birth. What we were really interested is to look at those windows of the exposures that we've talked about in the, before. When parents are reporting smoking only before birth, there is no association. When they're reporting smoking around the child after birth, there's no association. However, when we have those two hits, pre and post, this is where we start to see an increased risk of childhood leukemia. More interestingly, when we look at those very different molecular subtypes, we see that the association was seen only in the one who had the translocation 1221. Children with a type of leukemia that has extra chromosome is not associated with smoking. So here we have interesting time window of exposure and subtype specificity. When we look at the myeloid leukemia, I told you it's a rare disease, so more information is available from the CLC consortium. We did the same analysis for father smoking, and here we see the same association. When you pull all the data, we find almost 50% increased risk of leukemia with smoking. It's very difficult with countries from Europe to look at pre and post because there's no difference. People were smoking all the time. In California, we could catch a cohort of fathers who would stop smoking. But when you work with studies in Europe, this is not possible. So we cannot really pin down the pre and post. However, we looked at some of the kind of dose-response relationship, and each time we find that the higher the stronger the smoker, the higher the risk for all those different time windows. I told you about no association with maternal smoking during pregnancy and ALL. When we look at this also in the CLC consortium, same, we find no association. It's close to 1-to-1. There's no association. However, it was interesting to work with the consortium because we had different ethnic groups. And we were able to have enough data to look specifically at children from Hispanic backgrounds, white Caucasian, and other ethnic group. And here, interestingly or not, we do find for the first time actually an excess risk of childhood AML when the mother is reporting smoking, but only among Hispanic. So what does that say? I don't know yet. Maybe there is less a concern about recall and volunteering the information may be easier for mothers in Costa Rica, in Mexico, or Hispanic women in California. I don't know. Maybe there's some genetic susceptibility that are different. So it's still puzzling, but we do find an excess risk among Hispanic children. Let's turn now to other type of exposure around the house. We have looked at home use of paint and solvent. This is all self-report. It's not easy to get at this information other than using self-report. What we found is that there was an association with childhood ALL with use of paint, but not solvent for some reason, and that most of the risk was driven for use after birth. When we looked at those two subtypes I talked to you about, 1221 translocation and extra chromosome, interestingly, we have the same pattern that we found for smoking, which was that most of the association was seen in those leukemia that have the 1221 translocation. This is an interesting pattern. It's kind of recurrent, that exposure to those chemicals that have some similarities tend to increase a specific type of childhood leukemia. Likely, we were able to reproduce this finding in the Childhood Leukemia International Consortium. So that was very exciting to see that, again, the highest risk was being seen in this subgroup. I didn't show it here, but it was also very high in the MLL fusion, gene fusion that I showed to you that are specific to infant leukemia. So let me turn now to other work that we have done in terms of characterizing exposure in the workplace for the father and the mother. We have worked with industrial hygienists at UCSF and UC Berkeley to develop what we call a task-based job module to go back and ask more precise questions about the activities that the parents are doing. And that was, those questionnaires were derived from a interviews that were designed by the National Cancer Institute, and we kind of adapted this questionnaire to our population in California. So we had 19 specific job modules that were conducted. This work was done with many, many people. I'm just citing here Bob Guinier, who is working with me on some of those analyses. And he's also working with Brenda, so it's a nice interaction. But let me just go straight to the point. Because we are concerned about these different incidence rates in Hispanic and non-Hispanic white, we always kind of look at the analysis separately. So I'm going to show you here the findings that we have for Hispanic fathers that were exposed to, this table shows exposure to different type of organic solvent. So, you know, you can go down the list, but when you look at overall, any organic solvent was associated with a 70% increased risk of having a child with ALL. The highest risk seemed to be driven by chlorinated hydrocarbon, which are known carcinogen. It's a definite carcinogen in adults. But you see, you know, of course, a lot of them are correlated, and you see most of the risks are seen for all of them, including combustion exhaust, which has been found in many other studies. The intriguing part is that when we run the same analysis among non-Hispanic fathers, there is no association whatsoever. I see faces here, it's like, why that? I mean, do we have a systematic bias here that, you know, I mean, start to worry about some kind of systematic recall bias? Well, I don't know. Another explanation could be that our interview are not really able to capture the intensity of exposure. We tried, but it's still very, very crude. We are not able to really characterize the condition in which those Hispanic fathers are working. But likely, they are likely to work in a more dirty condition than other workers. And we know that it's well documented that Latino workers have higher incidence of injuries and work-related accidents. So, you know, one would expect that maybe Hispanic fathers are working in a more unsafe conditions. They don't use protective equipment maybe as well. I mean, there could be other reason than just maybe an artifact. So this is what the data are telling us right now. When I still wanted to try to identify which one of those organic solvents could be the driving force in a multivariable model, you could see that definitely chlorinated hydrocarbon was the one to kind of pin down. I'm losing precision, of course, because of the correlation between compounds, but you can see that there is a 2.2-fold risk of childhood ALL for those fathers exposed to chlorinated hydrocarbon. And it's still here when I adjust for other source of exposure. So chlorinated hydrocarbon are very volatile agents. So, you know, another question is that what is the mechanism? If this is true, compounds at home, the same way you would do for volatile, that you can still bring home. You're not here we are getting into the preconception, very critical time that is exposed to those carcinogenic agents that could lead to childhood ALL. So that was a very, very interesting finding, and the paper has been conditionally accepted and will be published soon. In terms of exposure to paint in the work setting for the mom and the father, we found no association. Remember, we found an association in the home for postnatal exposure, so the child is being exposed directly. However, when we look at paint exposure during the work setting, we find no association in our California study, but also in the CLIC consortium. Okay, I'm going to turn to other occupational exposure, which are pesticide, and thanks to Brenda to already, describe the landscape of what California is about. Our study here is being conducted in northern, central, and now southern California. As Brenda mentioned, there's a very high use of pesticide, and most of the workers are Latinos. So here, this is a very selected population to look at this exposure. When we looked at any pesticide that the father reported to use, we found 1.5-fold increased risk of childhood ALL. For the mother, there was nothing that was definite. We had different sources of interview to try to assess the use of the exposure to pesticide. Being a pesticide applicator, working as a farm worker, or as a gardener. You can see that the most stable association were seen with those fathers who were in closer contact possibly with pesticide. When we looked at different crops being used, it was interesting to see that the highest risk in the magnitude of a 4-fold was seen actually for those workers who are harvesting nuts. And I haven't been to California when harvest is happening, but I was told that this is actually a very dirty, dusty job. The way they harvest nuts, they actually shake the tree. They put some kind of blankets on the floor, on the ground, and then they just shake the tree and the nuts are falling. It's quite interesting to see that the rate of exposure could actually be through inhalation or dermal absorption. So this is an interesting observation as well. Again, to look at childhood AML, we have to turn to the consortium studies. Independent studies would be very weak. What we find here, remember there was, I think, no association with the mother being exposed to a pesticide and childhood ALL. Well, this is a different picture here when you look at AML. So this seems to be a very subtype specificity. Here we found that mothers exposed during pregnancy to pesticide, and those are studies from Germany, the US, Greece. We found, almost a 2.5-fold increased risk of AML. We also looked at other studies that were not part of our consortium just to have a fuller picture, because our group doesn't represent every single leukemia studies in the world. But you could see that, including those studies as well was still giving a risk estimate of about threefold. All the work that I have mentioned up to now was working with interviews from the parents. However, we know that this brings some limitation in terms of understanding the actual ingredients that the family could be exposed to. And for some of them, they cannot even know they're exposed to flame retardant or PCB, PBDEs. So we went to about 500, 600 homes of those participating families, went back to the homes to collect dust. And we've heard today as well that dust is an important reservoir of chemicals. And that children are definitely exposed to the dust and therefore the chemicals through their behavior at a young age. So we measured a lot of chemicals. It was interesting to realize that there was a correlation between the age of the residents and the number of chemicals that were detected in the dust. The older the house, the most chemical were measured in the home, as accumulation over time and layers after layers. In previous studies, we were able to see association between elevated levels of herbicide, PCBs, PAHs, and flame retardant. So in our study, we're able to identify association with those compounds. Unfortunately, we're the only one to conduct this type of studies, and it's, there's no replication at this moment. What we were able to do to kind of try to understand still the continuum between exposure and body burden, we were able to collect blood for some of the mothers and the children, and to demonstrate that the level that we were measuring in the dust was actually correlated with the level that were measured in the blood. So this is an important link to be able to demonstrate that what we measure in the dust, yes, gets in the blood. I mean, people know, but it's always good to see this in your own study to help substantiate your conclusions. So how much time do I have? Okay, good. So I'd like to turn to diet. We had, again, some nice background information about diets, and hopefully it's going to be a more positive ending of my presentation. But we've learned today that, healthy diet is good. A source of one carbon, what we call folate metabolism, is very important for many different pathways that are helping to synthesize the DNA, to repair the DNA for methylation, DNA methylation. So all these goods here are important to feed into those pathways. And there's no exception that we hypothesize that healthy diet or intake of some of those critical vitamins would have a beneficial effect on leukemia. So different sources were looked at. As you know, women who plan to have a pregnancy are likely to take prenatal vitamins. However, it was very interesting to see the prevalence of use of prenatal vitamins in the different countries around the world. And you can see here the United States. On the right side is vitamins after pregnancy, and on the left side it was, before pregnancy. You can see that in the United States, 95% of the women reported taking vitamins. However, when you go here to New Zealand, you have only 9%. When you go to France, I think it's very low as well, only 17%. Of course, the study period kind of span over almost 20 years. So some of the recommendation in terms of prenatal supplementation were different between countries. But the beauty of having variation is that you can actually study the association between folate supplementation and an outcome, which we are very limited to do in California. So we take advantage of this heterogeneity. I know that people don't like to see heterogeneity, but sometimes it's actually very useful. Here, this is a cartoon of all the studies that have contributed data and the risk estimate that was associated with ALL. And you can see that it goes from reduced risk to no association, and it tells eventually maybe to increase risk, but never significant. It overlaps all the time. So when we combine all those data and we looked at ALL, I'm going to look at that with you today. So we could see with very large number here, we have 4,000 cases and almost 7,000 controls. We could see that vitamin supplementation before and during pregnancy reduce the risk of childhood ALL, whether it was any vitamins, because it can be a combination of vitamins, or whether some women reported only folic acid. In France, for example, they're not going to have most of the time the cocktail of vitamins. It's going to be just folate. So here we could focus on folate. But you could see that there is a decreased risk of childhood ALL. We were actually interested to look at this effect within different level of social economic status. So it's very challenging when you combine data from different countries because there is so much heterogeneity into what we define as SES status. So the best we can do is to look at the education level, and as a broad surrogate of maybe healthy habits and healthy diets. And what we could find here is that this beneficial effect of having prenatal vitamin supplementation was actually seen mostly in those women who have no or primary education. So the added value of prenatal supplementation seems to be prominent in those women who maybe not have the background folate level. So that's this type of analysis that you can do in a consortium. With the childhood leukemia study, we were able to look at Hispanic and non-Hispanic women. And here we could see again that the most beneficial impact of taking vitamin supplementation was seen among Hispanic women who would take the highest level of supplementation compared to non-Hispanic white. So, I think it's interesting to keep in mind targeted intervention when you know that some subgroups may be more vulnerable. Finally, I would like to go over the concept of healthy diet in general. We've talked about not just looking at one thing at a time, and definitely diet is one of these a field where it's difficult to actually pull information from one nutrient versus another. So we've looked at, we've used the Healthy Eating Index as a overall score of poor versus good diet to try to comprehend all the different input that a mother would have. And we had to modify this index with our own interview, but it was close enough. And you can see that the higher the score, meaning the healthier the diet, the lowest the risk of childhood ALL. So that tells you that, yes, diet matters when a woman is pregnant or will plan a pregnancy. So concluding remarks, we've shown that there are different chemicals that can lead to the development of different leukemia subtypes. We've heard today that some of those chemicals are known already to cause other condition in children. So here talking about a cumulative impact of those exposures. We've learned about the importance of diet, and we are in the process of trying to put all this data together to look at the cumulative impact of the exposure itself. If you want to know more, you can consult the ebook, The Story of Health, that Mark Miller has put together. We have a section on child. You'll be able to learn a bit more than what I've presented today. Of course, we are continuing to do some work to understand the mechanism that will lead from exposure to leukemia, but I think the center has been very useful for us to already try to take action on what we have found, and there is no reason to wait. So we are really pleased to be part of a center that is really helping this agenda. Just get the word out. We can do something today.